and has kindly introduced us to our first panelist of the day, who's starting off this session, Dr. Brenda Restoule, CEO of the First Peoples Wellness Circle, who, again, Carol kindly connected us to in her absence. Dr. Restoule will be followed by Ellen Cohen, National Coordinator of the National Network for Mental Health, and then Mary Alberti, CEO of the Institute for Advancements in Mental Health. Thank you again, and I turn it over to Dr. Restoule.
Ani, Bojo, Wabsquestijnakas, Magisi Dodam, Dokis Dinjaba, Anishinaabe, and Dao. I come to you from the territory of Nipissing First Nation, and I thank you for inviting me to fill some very big shoes with my friend and colleague, Carol Hopkins. I'd like to talk to you today about some of the realities of mental health, or for us, what we call mental wellness in our communities. My focus will be primarily on First Nation communities because that is the work that both Thunderbird and First Peoples Wellness Circle does. As a clinical psychologist, some of my comments will be made from my clinical experience, but also from the work that we do in our organization supporting the mental wellness workforce in First Nation communities. What we know about mental wellness services in our communities, I would say, comes in two main statements. One is, I would see it as very much a patchwork of services that has always happened in our communities. And the second is that we have significant and many gaps in the continuum of care for First Nations people across Canada. So the reason that this is the case has a little bit to do, I think, with the fact that historically our services have been funded through the federal government, yet we know that mental health services are primarily held and provided through provincial and territorial services. And so there is a challenge there that automatically leads to gaps in services. The federal government has always looked at providing services to our communities in ways that are based on funding per capita as opposed to need-based funding. So what this has meant is that often the funding will support our community members living in a First Nation, and those amounts of dollars are based on the number of people living in the community. And so most of our services have often been in a prevention and a promotion service type capacity around mental health. And sometimes it has been very generic in terms of talking to people about avoiding infection and just living well. But it doesn't always address some of the more significant challenges that has happened to our community members over the last century when it comes to thinking about colonial traumas. And so we do see that sometimes some of our services that have been federally funded have been geared to addressing problems or deficits in the community. And what I mean by that is we've often been funded to address certain issues. For example, we have the National Native Alcohol and Drug Abuse Program, which is meant to address addictions issues in our community, and one of the longest standing programs to have been evolved that looks at mental health or mental wellness services. And NADAP-based programs can be anything from prevention and promotion to assisting in referrals for residential treatment and sometimes to aftercare. But the NADAP program is also one that began to highlight the importance of looking at culture as a significant and important variable in addressing mental wellness. And so I understand that my colleague Carol spoke about the importance of Indigenous knowledge and evidence as a critical base to understand how to address wellness. And I would say that the NADAP program was very much about that. It was about thinking about how we bring back culture, how we bring back our understanding of our wellness to help support and promote wellness. However, some of the other areas that has really focused on dealing with problems or deficits in our community is one such as the National Aboriginal Youth Suicide Prevention Program that looked at addressing suicide in our young people. This program started off very much as a program that was proposal driven, so it meant that not all communities had access to these types of services, and the suicide programs varied across the communities depending on how it was identified as a priority and what ways to address it. But a common factor in all of those programs and services, again, pointed to the importance of culture and language and Indigenous knowledge and evidence as being a critical component to addressing suicide in our communities. Some programs, some of our communities access programs that are serviced or funded by provinces and territories. And in those cases, they have often focused on specialized populations like child and youth mental health. Other times, access to programs are done through large groups such as territorial governments or through regions or through clusters of communities. For example, treatment centers, which are also NAIDAP funded, that have supported adult treatment centers and youth residential treatment centers, usually service a large region or geographical area, sometimes across one or more across the province. Others that have also looked at addressing things like trauma include our Indian residential school program that looked at addressing trauma, colonially based traumas and other forms of trauma. That has since been extended to looking at traumas related to murdered, missing Indigenous women and girls, and now our day school program. So again, that program is usually found at a regional level. And so we're starting to see a patchwork. There are some prevention programs in the communities. They're not always all the same. Then we have these programs and services across regions or territorial groups. And then we also see that some are provincially based. And that we can sometimes get additional access into our populations that funded out of in a First Nation. And I realized I forgot to mention one other program that is sometimes done through clusters is our mental wellness teams. And our mental wellness teams are often a collaboration of Indigenous cultural practitioners and mainstream practitioners looking to support mental wellness services in a community. In this case, and in the case I'd say of the Indian Residential School Program, all of these programs continue to focus on Indigenous knowledge and evidence, and they also take the lead from the communities about what are the priorities and what are the needs. So what I'd like to say is that there still remains a lot of gaps in terms of not all of our populations have their needs addressed. And we need to be able to work with our provincial system who holds the funding dollars to be able to do that work. So many of our communities, as I've stated, have noted the importance of culture as central to addressing mental wellness. And we have to be able to recognize that Indigenous people, First Nations people have talked about the First Nations mental wellness continuum framework as a model to addressing wellness. And I'll just say very quickly that a big part of it is recognizing that culture as a foundation to our mental wellness services. It means supporting the Indigenous social determinants of health with culture as a foundational piece, looking at breaking down silos, looking at shifting from input to individuals to outcomes for families and communities. It must be designed and led by communities based on their needs, their priorities, their values, their language, and their culture. And it calls upon other systems to provide quality care and to be competent and to ensure that they're collaborating and partnering with the First Nation communities and recognizing there is a need for enhanced flexible funding. During the pandemic, we've seen that those gaps in services and that patchwork has really highlighted just how difficult the mental wellness services are for First Nations in being able to get access to quality service. It has shown that there's a burden within our First Nation health system and that we don't have enough in our workforce to be able to address the needs within our community based on the current resources that are there. We have seen increases in mental health challenges to substance misuse, to violence, to anxiety and depression, and triggers to trauma and colonial trauma based on some of the public health measures that have been instituted for the physical safety of our community members. We have learned to pivot to virtual platforms through the treatment centers who have been able to pivot and provide online residential type programming to people in their homes, as well as to mental wellness teams who have also pivoted to a virtual platform and Indian residential school member workforce as well. We though, however, see that we have challenges in connectivity and the infrastructure in our communities because it is lacking. We continue to have difficulties, particularly in remote and isolated communities who don't have the infrastructure to allow for those accesses to be present. And in many cases, our membership also doesn't lives in poverty and therefore lacks the access to the technology for virtual platforms. What we have seen instead is the shift back to land-based activities. Many of our communities went back to going on the land, teaching people to connect to the land, to harvest medicines, and to use those medicines during this time. We also saw that there was some use of access, using virtual access to provide access to cultural teachings, cultural activities, and language, things that could help really inform and improve wellness. We also saw that we use our social distance measures for community activities. So some communities did drumming activities that you would hear throughout the day. Somebody would stand at their home and they would drum and they would sing as a way to help manage mental wellness or anxieties and worries and stress during this time. We saw a shift to investing in food security, so people did not have to leave the community and didn't have to worry about financial needs, and also to ensure that we were nourishing people physically. And so there was a big investment in that area. We also saw an investment in harm reduction activities within our communities. In one community, they looked at bringing in managed alcohol that they distributed to the community members, and they talked to them about harm reduction approaches. We did see reduced access overall, however, to community services as well as provincially based services when they were needed by our members. This was sometimes because the services were closed or unavailable to the public, such as treatment centers, or because our communities had restricted access and so they couldn't leave to go and access provincial services. And in some cases, provincial services were also not traveling, and so there was lack of access to those services. So for us, our challenges remain with those restricted access that sometimes cause concerns for some of our members related to other challenges for them. For example, people who were in residential treatment programs who may have had to leave or couldn't go in because they were closed, had concerns about their child welfare needs, where sometimes they were required to go and get access to residential treatment in order to get access to their children and have their children return home. So having to work and support them to get other means of getting their needs met so they can get their children, get access or have their children return to their home, or included in the justice system. Some people needed to access these types of service to address their justice needs. And so it led to other challenges that we continue to see. I'm not sure where I am in the 10 minutes, but I will say very quickly, my reflections are this: how can we support First Nations communities and Indigenous communities? One of them, I think, is by advocating for Indigenous-led initiatives on mental wellness, by supporting things like the Mental Wellness Continuum framework that gives a really clear picture of how we can help communities to do the work that they have identified need to happen in their areas and in their communities. We can also advocate for provincial and territorial governments to be better engaged on Indigenous defined mental wellness services and how they can invest in those services that come from Indigenous models and based on Indigenous outcomes and evaluations. Finally, I think we can also advocate for investments on with Indigenous communities to have better access to virtual infrastructure. Right now, our federal government is saying by 2030, but that is not soon enough. We need that to happen much sooner for our communities to have access to the services that they need when they need it and where they need it. We need to be able to advocate for the Indigenous social determinants of health with collective outcomes around families and communities instead of inputs to deficits and individuals, by looking at strengths-based approaches to care. And we need to ensure that we advocate for enhanced funding for Indigenous mental wellness services that invest in Indigenous knowledge and evidence. Thank you for your time, and I hope I was within the 10 minutes. Miigwech.
Thank you so much, Dr. Restoule. I think you were within the 10 minutes, considering that we started a little bit later. So I welcome Ellen to please unmute and turn your video on, and we will begin with your the next presentation.
Hi, I've unmuted. I've never really presented at this, so hold on.
Thanks so much, Ellen. We have your slides up, so just let me know when you're ready to go on to the next slide.
Okay, because I'm looking for, okay, so, oh, too many things are open.
You are good, Ellen. You've got slides
I'm
up.
so sorry. I am so
Okay.
sorry, everyone.
Don't you worry. You just find your remarks. You're in good
Okay.
shape otherwise.
All right. Okay. Okay, perfect. Okay, so good afternoon. I'm really sorry about that. I'm very nervous and I don't do well at presentations. So, and Dr. Restoule, you would be happy, would have been happy if you went over time. Anyways, good afternoon. My name's Ellen Cohen and I'm with the National Network for Mental Health. I'm honored to be presenting here today at your 5th annual summit, Redefining the Future of Healthcare in Canada, on this December 3rd that marks the International Day of Persons with Disabilities. The National Network for Mental Health is an incorporated non-for-profit charity, the only non-diagnostic mental health consumer-run and directed organization in service to Canada. And over the past 6 years, the National Network has been actively participating within the disability community. And along with our partners from civil society, we've been working on human rights and social justice issues that are relevant to all people with disabilities, including mental illness. The NNMH plays a pivotal role bringing the mental health perspective to the disability table and bringing the awareness about the intersection of disabilities and mental health into this mainstream mental health sector. Today, I am talking to you about mental health and disability in this situation before the pandemic, the current situation, and the way national networks moving forward. And the 3 points for this panel are the state of mental wellness pre-COVID and related services, how the pandemic exacerbated this situation, and our recommendations for moving forward. With the rapid innovation response of the government, Health Canada and Public Health Agency, they did great stuff creating a mental wellness portal that supported the wellness information and information in regards to professionals, peer support, psychiatrists, psychologists, all that were available online through this website. However, that being said, they were taking care of the general population. And many, many people within our communities, the disability mental health community, were left behind. Plans now for future interventions post-pandemic and virtual transformations that are going to be occurring as a result of the pandemic. We need to ensure that they are inclusive and that everybody has access to those people with psychosocial disabilities, as well as people who have mental health issues and psychiatric disorders, who have disabilities, from the deaf community and all other communities within the disability community, intellectual disabilities. Oftentimes, the people within the disability community, the advocates of the disability community, have to search themselves for their own services, and they're forgotten. And once again, during this pandemic at the beginning, they were forgotten. The way forward for mental health services and supports is to focus on the workforce, which absolutely necessarily is important, and essential workers. However, we need to remember that people with disabilities are also in the workforce, and they are also in need of mental health supports and services. I've just got some statistics for you. Canadians with mental health disabilities are over 2 million. And I can't see I'm sorry, I can't see my slide. Over 2 million Canadians aged 15 years and older have mental health related disabilities, and that's 7% of Canadian adults and youth. 4 in 5 Canadians have mental health related disabilities and at least one other type of disability. Among women, they are more likely than men to have a mental health related disability. And over 1 million Canadians with mental illness say that they require counseling services from a psychologist, a psychiatrist, a psychotherapist, or a social worker. 519,400 receive some counseling but require more, and 286,400 required counseling but did not receive any at all. And these are from Canada's Survey on Disability Studies, and it was published in 2017, 2018, the first one that's been published in quite some time. Before COVID, the mental health system, despite the billions of dollars of funding that flowed into the system, into mainstream mental health, or as I call it, mental health industry, before they were, with all the funding that was flowing into the mainstream healthcare system, people with psychiatric disorders and major mental illnesses continued to fall through the cracks. And this is prior to the pandemic. The Canadian mental health system has been failing people with mental health conditions, severe mental illness, and it's been lacking the capacity to meet the demands of people with mental illness for far too long. And we've been advocating that. Add to that the people with disabilities from the deaf community and other intellectual disabilities, sensory disabilities who have mental health issues are now even more part of the mental health community and the seekers of mental health supports and services. How has the pandemic exacerbated the system? Oops, sorry. I'm looking at my notes too, so sorry. Since the pandemic, the government has moved quickly to try to create financial security in some regards, with the CERB, and that was our first piece of evidence that people with disabilities in the deaf community who were suffering with mental health issues and who were just within a situation where we're all locked in and we were all stuck inside and needing extra funding, did not have access to that until there was an outcry from the disability community. And once again, they were left behind. Our major concern has been evidenced with the first wave of COVID and people who were suffering from mental illness and those with mentally ill. One of the examples, as I said, was the financial support through the CERB. It was rolled out, and persons with disability and serious mental illness were the last ones to be thought of and receive it. Disability supports programs still don't reflect the cost of living needed for people with disabilities, and the cost can be even more now that people have no access to public transportation. They need to reach out to get groceries, to get supports and services that they would otherwise be able to go out sometimes and do themselves. Since the pandemic, the web resources that were created were deficient for serving the disability community. We have formed a mental health disability pan-Canadian COVID response committee, and we have a group of people from across the disability community to talk about the mental health needs within the disability community. Mental health is something that's constantly forgotten within the disability community, and it's a tough fight. Somebody was saying earlier that the lens that is used to look at mental illness is the medical model, which looks at the disease aspect, or the symptoms and the treatment, whereas within a social model, we're looking at the barriers that are created that don't allow for people to participate in community. And during the pandemic, we're isolated as it is. And I say we're because I too am a consumer of mental health services. I also have episodic disability. So I am very much a part of my community. Mental health service. Sorry.
So sorry, Ellen, it's Leah speaking, and I hate to interrupt because this is very interesting, but just if you could finish up in the next minute or so. I know you're already in your recommendations to move forward. Thank you so much.
So people with mental web resources that are created. Let me go to that slide. Sorry. Moving forward. Okay, I have to get there, sorry. So moving forward, we need to be looking at people to co-design programs together with people with disabilities. People with mental health issues need to be included in those designs of programs. We need to build the programs and interventions with people who have lived experience with mental health issues, and that they need to be truly responsive and reflective to the community needs. Another thing is, one of the things that being in a disability community and being a person with a disability, we don't ask for what we need, and this is our right. It's our human right. We have a right to mental health and physical health, and we need to make sure that we all speak up and ask for what we need, and also reach out and advocate to the politicians, to the bureaucrats. We need to let them know that this is our right, and it's not just a piece of privilege. And one of the things, and one of the advocacy issues that I'm grappling with is the mental health community is very focused on the medical model, and we need to help them to see that there are other models that they need to consider, and we need to be looking at the whole person and not just the mental health aspect of that person. They are not their illness. We are people with needs. And thank you very much.
That's a great way to turn it over to our next presenter. Thank you very, very much for walking us through all of that. And I'll ask Mary to please unmute yourself and start your video and share your slides. Thank you again, Ellen. We'll come back to you both in question and answer.
Thank you so much. So it's a pleasure. I want to thank the organizers of the event and the conference. It's really great, and also for embracing mental health and some of the things that we have seen and what the future will hold for mental health as well. And so proud to be on the panel with my colleagues here. So I wanted to just start off by introducing you to the Institute for Advancements in Mental Health. We had the privilege of having to rebrand our organization right in the middle of a pandemic. At the beginning of the pandemic, we were formerly known as the Schizophrenia Society of Ontario. And about 3 years ago, we started down the road to really look at our name and the people that we served. And one of the things that we felt was very important to us to understand the individuals and families and people we worked with, and really understand if our organization was really resonating with them. We found out very quickly that what people told us is, and we feel this is very important, is that they no longer wanted to be known as a diagnosis. That mental health was really about being seen as a whole person and being seen very holistically. And a lot of the social determinants of health is what is really important for people with mental health issues and mental illness and living with mental health challenges. So that was really our inspiration for rebranding into IM, the Institute for Advancement in Mental Health. So I just want to take you through some of what the organization does. Is our mission is around innovating, supporting, and driving change with people with mental illness. And this is a fundamental change. As Ellen was saying, oftentimes in the mental health system world, a lot of what we do is very top down. And we often don't listen to people impacted by mental illness and people experiencing mental health challenges, which is something very much we would do if we were in a corporate sector or in a business sector. We would want to be able to meet the needs of our customer. So IM has pivoted to be able to drive everything we do alongside with people who live with mental illness. Beyond that, our beliefs in the organization is that the mental health community has been very siloed and often very times related to just a mental health system. We really believe that it is time to change that, and that it is not about which organization or which hospital, but all of us working together. Because if we come together as a community of people, we fundamentally believe that we can support people in a much better way. So here are some, we believe in partnerships and working together and not alone, and innovation. So one of the big pivots that we've done is we feel that the mental health system has been delayed in embracing innovation and embracing different ways of responding to folks who need help and different ways in responding to prevention. We also believe that within mental health, there has to be tremendous compassion and respect always for what we do, the people we do it with, and that we really need to look at impact and understand what people need so we can work together and come up with solutions for people, real lives, real problems. So as an organization, what did we see pre-COVID? We saw a system that was already overburdened and overwhelmed. It was a system that was not able to respond to mental health needs. We were experiencing access to care and access to service, enormous wait time for people trying to get help in the system. We were also experiencing that there was a lack of adapting and onboarding new ideas and new solutions to care. So oftentimes, we talk about what is out there. What are some of the things that communities have invested in themselves, even on a volunteer basis, and adapting and supporting individuals with mental illness and mental health challenges. So things that we saw, although we had peer-to-peer programs, and we say we value peer-to-peer programs, they were not fundamentally seen or still seen as part of a mental health care system. We often ignored, in terms of the lack of innovation, is understanding the experience of caregivers as well, and where caregivers, and when we talk about caregivers, We define that as anyone in a supportive relationship to somebody with a mental health challenge or a mental health illness. We saw there was a resistance to looking at doing things differently and kind of following our traditional service modalities in the mental health system. Our mental health care system very siloed in our approach. We saw real disparities between hospitals and community working together, between folks living with addictions and mental health issues. Where could they go and get support and care, and how could organizations supporting both of these issues work together? The system that was extremely overburdened and underfunded. And although we don't always need to have lots of funding for what we do, but when we look at the percentage of people impacted by mental health issues and where and how we're allocating resources, there are a lot of folks who are not getting the help they need when they needed it. The lack of access to services was a huge issue and continues to be a huge issue pre-COVID, in that services were not accessible, both from a cultural language perspective, were not geared to communities and the needs of communities, and they were just hard to get into. So oftentimes seeing wait times for services of 3 to 6 months, if even that. Also a very non-holistic approach. Oftentimes folks who live with mental illness or mental health challenges need to have their caregivers, their friends, their families involved in their support and their care. And there was very much a discounting of the system being as holistic. We've seen it in younger populations of kids, of course, and children impacted by mental health issues, but how does that carry on through the lifespan? And we see that the system really fails to look at individuals as people and very holistically in terms of what they need and what they feel they need and what would help them in their resilience and recovery. So some of our first wave observations highlighted what we saw, and our organization very quickly had to pivot. As we went into the first wave, we were an organization that did not provide virtual services. We provided telephone support. We had to quickly understand how to change. But what we saw at the beginning is just the disparities in our mental health system. We saw that significant amount of programs closed and funds for mental health programs were reallocated to other parts of the health system. So in Ontario, we really experienced a suspension of programs, a closing of programs. So what we saw as an organization were people were looking for help and all kinds of help. And we also saw that people were impacted by the pandemic in very many different ways, and that their ability to get equitable access to services was not there. We saw significant gaps in funding availability and organizational needs. So I'll just, as a charitable organization, about 20% of our funding comes from government. The rest, which we have to raise on our own. So as many others in the charitable sector, and I'm sure many of you have heard this, it has been such a difficult period to be able to maintain services and operations, especially in the mental health sector. So our organization, as well as other organizations, had to decrease staffing. And while we were decreasing staffing, the impact that we had a 50% increase, above 50% increase in individual clients that we were seeing. We found that a lot of vulnerable populations were disproportionately affected. And we also saw that folks who were living with mental illness that had pre-existing mental health conditions were even more isolated than pre-pandemic, but were extremely isolated in the first wave. And we saw a lot of ongoing challenges with coping and isolation. So what we found is that people needed to touch base regularly. People needed help almost on a daily basis with dealing with the challenges that were going on. We found a lot of people reaching out to us with first-time mental health challenges that they had never experienced before and didn't know where to go, what to do, how to cope. So that's just very basic of some of the initial things that we saw. So as I mentioned, starting March the 16th, our operations became remote. We pivoted very quickly. We had to understand how to embrace video conferencing. We had to go online, and we had to extend our office hours into evening hours to be able to respond to what we were seeing. All of this without knowing how to do this. And just to quote Kwame McKenzie, who's been one of the speakers at the conference, is that, you know, the mental health system has had to pivot quickly in 6 months, what's taken us 25 years to talk about. So I think it was sort of an abrupt change that we had to go through. We prioritized, we had to as an organization with the volume of calls that we were experiencing. And I would just say this is not unique to us as an organization, but to many of my colleagues in the mental health sector, is really understanding how do we deal with the volume, how do we deal with the need. And that coming from the sector that we come with is that embedded in us is to support people who need help, and knowing that the normal places where people might have been able to access care, whether it was through some social support programs or whether it was through some of the clinical programs, was just not there for them anymore. And we delivered many of our groups virtually. So we expanded our modality of how we did things, really to be out there and give people that opportunity to have the support that they needed. And I can just give you an idea of what we saw by going virtually. We were able to expand our services across Canada. We saw people coming from across Canada. At times, we would have on our virtual programs 100 people on a call or on a Zoom call, asking questions, talking about their needs. So it was quite overwhelming for the organization, but quite overwhelming of the stories we heard from people as well. So what have we learned? So moving virtually was a very necessary step, both for the organizational survival that we had, but also to be able to meet the needs of our customers and clients coming to us. And this was not easy to do. It came with a lot of challenges and barriers, and we just had to understand how to do it. As has been mentioned before, what we've also noticed in the pivoting that we've had to do, the lack of access to reliable internet and people understanding how to do Zoom, how to function in this way. And also giving up of the face-to-face contact and being able to come and see someone in person has had a great impact on people. There is significant financial burden on organizations. We don't know how many of the organizations in the mental health space and mental health programs will actually be able to make it and will be able to survive. And the loss that will be at the community sector. And we've also learned that in order to survive in a very different world, you need to be very agile. And oftentimes in the mental health sector, our system of care is very traditional and may not be as agile and be able to meet the demands and the needs and be flexible enough to do that. So post-pandemic, there is an immediate need to rethink how we plan for a future of mental health. We are embracing at IM and with our community partners a future foresight initiative that will develop a report and scenarios given to the Canadian landscape on how we need to plan for better mental health and what will that look like. And how can organizations and partners and community-based groups be able to respond to what we are going to be seeing now and also going forward? How do we adapt to this new normal? There will be no going back from where we are now. It will not be the same as when we started down this road. So what will that mean for us? Also, what kind of financial considerations will be invested in the mental health sector? And this is of grave concern is that with programs having closed and services having closed, will there be funding to reopen? What will be the mental health recovery model that we will have to look at? We've also seen, and I think this is very positive news, is that mental health is no longer just the mental health system, but we've seen the corporate sector, we've seen workplaces come up to the task of changing and the task of embedding mental health into the work that they do. So I think we now need to think about not just a mental health sector or a mental health system, but a mental health space. And that realigns us to the vision of our organization, which is redesigning society for better mental health. There is a huge need to come up with unique solutions to fill a lot of the gaps. I think post-pandemic, and we need to start thinking about it now, there are many great initiatives and programs and services that have been given birth through the community and through people who live with mental illness and mental health challenges. A lot of these are very evidence-based initiatives and services. How do we understand and integrate these as part of our mental health space and a good mental health response? And how do we really together think about doing things differently? So through what we are proposing as our innovation platform, which is a collaborative platform in the community, how do we talk about mental health challenges and come together as a community of partners to come up with mental health solutions that can be scaled very quickly and that really respond to the needs that we have? And these mental health solutions, through an innovation platform, fundamentally engage our customer and the customer experience in the development of these solutions. Post-pandemic, we really need to understand health and holistic health and consider both physical and mental health. So mental health is not just one little box that we're looking at, but it's actually just a fundamental part of everything that happens with our health and in the health system. And there is a real urgency to start working even closer together and understanding how do we share resources, how do we collaborate, how do we understand the issues that are out there, and how do we come together around solutions to these issues. And this is not just folks in the mental health system, but corporate partners, philanthropic partners, scientists, interesting and unusual partners alongside with our customers. So that's it. Thank you.